Hello, and welcome to ACR Journals on Air podcast. I am your host, Vicky Shamagam. Have you ever tried to buy or sell a home? If you have, you're probably familiar with the real estate refrain, location, location, location. Well, location is not only essential for the value of your home, it can also impact the healthcare that you receive. The manuscript we will be discussing today is Geographic Variation in Disease Burden and Mismatching Care of Patients with Rheumatoid Arthritis in the United States. It was recently published in ACR Open Rheumatology, and a link to the manuscript and disclosures are in our show notes from today. I'm thrilled to be joined by the first author of this paper, Dr. Sharon Dowell. Dr. Dowell is a graduate of the University of the West Indies. She completed her internal medicine residency at the University of Connecticut and her rheumatology fellowship at the University of Maryland. She was subsequently on faculty at Howard University in Washington, D.C., where she rose through the ranks to become Associate Professor of Medicine, fulfilling the tripartite mission of medical education, research, and clinical care. And she is now the Medical Director for Rheumatology at NEA Baptist Memorial Hospital in Arkansas. Also joining us today is Tracy Johansson. Tracy is the Senior Director of the Rheumatology Informatics System for Effectiveness, or RISE. And by way of full disclosure, I should mention that the RISE registry was established by the American College of Rheumatology, who also support this podcast. Welcome to the show, Sharon and Tracy.
Thank you for having us.
Thank you for the invitation.
So this study looks at some incredibly complex healthcare issues that significantly impact outcomes, particularly in the US, and we'll return to those shortly. But I wanted to start, Tracy, if you could, with you giving us an orientation to the RISE registry, which was the data set used in this study. The RISE registry is pretty unique. It was designed originally to help rheumatology practices comply with some of the mandated quality measures, the dreaded Quality Payment Program Merit-Based Incentive Payment System, or MIPS, reporting. But it's grown to be so much bigger than that. Tracy, can you tell us a little bit more about RISE? Where does the data come from? How many patients are in the registry? And how can researchers request use of the data for their research projects?
Yeah, absolutely. So the RISE registry was first launched by the ACR back in 2014. And as you noted, the goal of the registry has been to help rheumatology practices complete their federal reporting requirements, track those changes, and report for those programs as they evolve over the years. And as you noted, we have been able to help our practices report for the dreaded MIPS program and continue to do so to this day. One of the things that has been wonderful about the RISE registry is how many practices that we've actually been able to connect to over the years and the amount of data that we've been able to aggregate over those years as well. So we have currently about 300 practices across the country that participate in the registry. That's about 1,000 providers looking at about 3 million patients. And over the years, that's gotten to about 31 million visits.
That's incredible.
Yes, it's quite extensive. And it's been, really a really wonderful resource for the rheumatology community over those years, because in particular, one of the things that's unique about the registry is that we actually work to extract the data from the EHR systems of participating practices. So we're getting real world clinical data from these practices. We take that data in, we map and clean that data, and then we're actually able to analyze that data and feed it back to these practices to tell them how well they're doing on the quality metrics for the quality of care that they're providing their patients. So while it has been really a big resource for reporting for the federal, based on the federal requirements, it is just also an incredible quality improvement tool for our providers as well.
Tell us a little bit about how researchers can request the use of data for their projects.
Yeah, absolutely. So with so much data from so many practices and on so many patients, we wanted to be able to make this available for research purposes as well. One of the things that we really like to be clear about is we don't actually provide the data directly to researchers. What we do is have some contracted data analytics centers that have the expertise in working with the EHR data and are led by a rheumatology expert. to run and manage these analyses. So anyone that's actually interested in using RISE data can submit a request to the ACR. We will process that request, and we do not evaluate for scientific acceptability. What we really focus on is ensuring that we can actually answer the question with the data that's available through RISE. So we have a select group of volunteers that help us conduct that assessment. We work with requesters to refine the research request to make sure that we can get it through to the actual analysis project and the actual analysis. So once the project is approved, we actually will contract with the requester and contract with the Data Analytics Center, and all the groups will work in a very collaborative and iterative process to develop that analysis, actually execute that analysis, review the results, make any adjustments that might be needed, and then get that through to the point where we are actually getting answers to the questions that are being asked by our researchers, such as Sharon.
And Sharon, from the other side of this, as the researcher kind of asking the primary question, how did you approach RISE? Did you have to have grant funding for this study, or just being an ACR member, did that let you into the data from the registry? Can you talk about what it was like from the researcher standpoint?
Yeah, sure. In a way, it was easy, but not as simple as you described. First, I want to give kudos to Gail Carr, as this idea was really her brainchild. Being an ACR member affiliated with the VA in Washington, D.C., and Howard University, the RISE subscription fees were waived for the project. However, as Tracy alluded to, there's a lot of management and analyzing of data, and it required an entire team. We worked with Jeffrey Curtis and his amazing team at the University of Alabama at Birmingham to bring these findings out of the dark and into the light. And to do that, we received support from the DC VA's Institute of Clinical Research. And so for others thinking of doing something similar, I think it's fair to say that some level of funding would be needed to complete these sort of complex data analyses.
Yeah, and so RISE is a fantastic resource, and I think this study uniquely gets to some of the overarching goals of the ACR in kind of focusing on improving patient outcomes and demonstrating the value of rheumatology in the healthcare system. Can we talk a little bit about why you did this study in the first place and the collaborations that kind of led to the study being designed? So you worked with both Gail Carr and a number of other investigators from the Association of Women in Rheumatology. I'm wondering, could you tell our listeners a little bit about AWIR and how that collaboration coalesced?
Right. The Association of Women in Rheumatology, or AWARE, was founded in 2014 with a mission to promote the science and the practice of rheumatology, and also to foster the advancement and education of women in rheumatology. And doing this while also advocating for access to high quality care for all of our patients. In this way, AWARE was committed to education, research, and advocacy, and each arm is interconnected, right? Data helps to inform and to drive advocacy, and hence research was needed. Presently, the membership spans multiple states with over 1,500 members in the US and global partners who have a similar vision around the world. With respect to this particular study, I want to say the initial idea to look at the RISE registry emerged from findings from an AWARE member study with the same co-authors, where they looked at a similar concept of RA disease burden. And by that, I'm talking about the whole burden of having rheumatoid arthritis, of comorbidities, of managing social situations. And they also looked at insurance across the different regions for members who were part of AWARE. We found that cost sharing was a significant burden to patients, even when copays were low, especially for those patients who had active disease and high comorbidity, because there's a cumulative expense, right, based on multiple specialist visits, multiple medication prescriptions. Intriguingly, There were regional variations with high versus low co-pays for medical visits and for prescriptions. And there's also regional variation in comorbidity and RA disease activity. Now, this manuscript is currently under review, and we hope to have it published soon as well as a complement to what we're discussing today. But what we could not account for in that small study was socioeconomic status. And we wanted to look at the whole patient with RA, not only the disease measures, right, but comorbidity, access to care, the environment in which our patients lived. Because in the real world, we are not just managing a disease or a condition in isolation. All of these factors are important. So going to RISE, which was one of the largest rheumatology-specific registries that seamlessly incorporates this information, as Tracy alluded to, really just seemed to be the next step.
Yeah, and so using RISE's data really made sense here. And I wondered, could you dig a little deeper into the data? In addition to the standard measures of RA disease activity, the RAPID-3 and the CDAI, one of the components you evaluated was a measure of comorbidity called the RX Risk Comorbidity Index. Can you tell us about that measure and what made you select it?
The Treatment Risk Comorbidity Index is a pharmacy-based measure of comorbidity, and it's becoming a lot more popular right now. It basically uses the documented prescription medicines entered in a medical record to estimate the number of conditions that are being treated out of about 46 different conditions. And it has been shown to correlate well with the other comorbidity indices that you may be more familiar with, right? Like the Rheumatic Disease Comorbidity Index, or the RDCI, and the Charlson Comorbidity Index. One of the challenges, which we'll talk about a little bit later, with registries and real-world data is documentation. In this case, the documentation of the non-rheumatic diagnosis codes, which we would need to assess comorbidity for the usual comorbidity indices, was lacking. So the treatment risk was a more reliable indicator of comorbidity in this analysis for that reason.
You also look at another measure called the Area Deprivation Index, and that's a federally developed measure that's used to assess mortality and disease prevalence geographically. So this information, I think, comes from the federal government based on zip code, but is already incorporated into the RISE registry as part of their measures. Could you tell us about that measure, and why did you include that particular measure in the analysis for this manuscript?
We thought it was really important to consider social determinants of health and their impact on health outcomes in RA. As you mentioned earlier, location is really important. The neighborhood that we live in determines our access to green spaces for exercise, our access to health stores and to healthy food. And by linking that to this, it really does significantly influence our health behaviors in general. And we wanted to incorporate these factors, and the ADI allowed us to easily link this neighborhood level information to the patients enrolled in the RISE registry. Just measuring socioeconomic status or a person's own wealth is not enough, because the neighborhood itself also has an impact on our health. On a personal level, I truly believe that as healthcare providers, we cannot only just treat the person, but we must be aware of these additional factors to provide actionable and relevant patient-centered solutions. And of course, at a national level, showing these linkages allow us to advocate for policies that can improve our outcomes for our patients.
Yeah, and I think that's so important. And I think it's important for our listeners to know that this data is there. I guess this Area Deprivation Index is available within the RISE registry. So, you studied it specifically in regards rheumatoid, but it could be used to study other rheumatic diseases as well. I loved your analysis in this article, and particularly your little bubble plot map, which I thought was really cool. It's pretty hard to talk about that without some description. So I wondered, could you tell our listeners what you found and give us a little bit of discussion of the findings of this study?
Yes, we love the bubble plot. I think like the old adage says, right, a picture is worth 1,000 words. And that really does tell the whole story. For this analysis, we had about 185,000 patients, just a little bit under that, from 182 RISE sites. And we were looking at geographic variation, and we defined the geographic regions as the Midwest, Northeast, West, and South, just to give some context. Now, most of the patients were predominantly non-Hispanic, white, and female, not unexpected for RA. And one of our most significant findings was that patients in the southern practice sites or southern location had higher levels of RA disease activity and also had higher levels of comorbidity than in the other areas. Another interesting fact that we noted was that sites in the South also had a significantly higher proportion of patients, about 2 to 3 times the level of other sites, who were from predominantly high ADI neighborhoods. And really, that means neighborhoods where there is high social deprivation. I mean, this is important. It correlates with national census data that show that some of the poorest counties are in the South. And with this information, we can advocate at both local, state, and federal levels for policies that improve neighborhood environments to benefit our patients. We also found a correlation between high comorbidity and RA disease activity, which is something that we all need to think about. Probably there's several reasons for this. High comorbid disease may limit options for effective RA therapy because of medication interactions or adverse effects. Patients may find the cost of going to multiple specialists or taking multiple medications to be a barrier to care, especially if they can't afford the copays. So there are so many things that can cause that association, but it's something that we all need to think about as we treat our patients. And then lastly, patients with high RA disease activity and high comorbidity were most likely to be federally insured. And I think that is like fascinating. In a way, it's not surprising, but when you think about it, and with some of the other data we'll discuss later, it is really astounding.
Yeah, and I guess that brings me to one of my other questions, is that I was kind of intrigued that many RISE practices had actually fewer than 20% Medicaid patients. And so in many practices, it was even less than 1%. Do you think that's because Medicaid patients tend to go to academic centers that are less likely to participate in RISE? And does that kind of have impact on this analysis, or is a drawback of this analysis?
Yeah, I think, that is possible. That is one of the limitations that we discussed, that academic centers are not really well represented within the RISE registry. Regardless, though, I think it still reflects that this burden of care for these highly complex patients, those who have high RA disease activity, high comorbidity, lower socioeconomic status, is carried by a few providers, whether those are providers in academic centers or not. Because I think it's safe to say that in most states, the number of private rheumatologists probably outnumber the number of academic rheumatologists. And even taking that into account, from these data, about 50% of Medicaid patients and 50% of high ADI patients in this cohort alone were cared for by about 10% of the RISE practices, about 20 practices actually. So even with this limited cohort, we see that the majority of these socially deprived complex patients were being cared for by a minority of the practices within the analysis. And as we think on this, there is a need to ensure that physicians caring for these patients really have adequate support. And we can talk about burnout and all those other issues, right, which you have to think about here. And we also have to find ways, I think, to encourage the other providers to assume roles in caring for these patients as well.
Yeah, I completely agree with that. And I think it is actually something, as we think about the larger problem of physician burnout, that really matters and really is something where the ACR could help the provider community as a whole. You had also some interesting findings about how far some patients travel for care. Could you share some of those with us?
Yeah, we found that patients in the South and the West generally traveled the furthest to care. Living here in the Midwest, no, I'm not surprised because these states are large and the distribution of rheumatologists are it's not high. I mean, overall in the cohort, about 3% of the patients, which is about 5,500 patients, traveled more than 200 miles.
Yeah, which is mind-blowing, right?
Right? Exactly. However, most patients with RA did reside within 15 miles of their provider, and we didn't really expound on that. But when you think about it, 15 miles is roughly about 60 minutes of travel. So they're still about an hour away from their providers. And that could pose a barrier to care in some patients. I think it would probably be good to do, a further analysis looking at shorter distances to see whether we see any sort of differentiation in care outcomes. We hope that telemedicine can be used to bridge this divide to make care more convenient and easier for patients to access. And this is another area where we can be advocates for our patients, on our own and through organizations like AWARE and ACR as well.
Yeah, I completely agree. And, there are some real, I guess, limitations to the RISE dataset because even outside of the academic practices, it doesn't include every rheumatology practice in the US. And there are still some regions that are not well represented, including some areas that we inherently know have quite limited rheumatology access. So, for example, New Mexico isn't well represented, North and South Dakota, they have no bubbles on your map at all. So RISE is kind of a convenient sample, but is telling us something really important, right? And should this data be an impetus to sort of look at other data sets to investigate some of these correlations further, do you think?
Well, I think that data, more data is always better. It gives you a more comprehensive picture. But I guess for me, I am struck by the lack of data points in that it sort of highlights again that workforce distribution and shortage area, right? On its own, it really says that we need to do a better job to ensure that all patients in all states have access to care. And again, this is another priority area for our organizations.
Yeah, and I'm going to draw Tracy back into this discussion actually to speak to some of those issues. Tracy, could you share with us kind of commitments from RISE regarding using this data to support studying workforce issues and issues that impact access to care for our rheumatology patients?
Yeah, absolutely. So, with the registry, our core work really is trying to help clinicians ensure that they're providing that quality of care so that the patients are accessing the highest quality care that they can, and also easing some of that administrative burden that potentially leads to burnout among rheumatology clinicians. And then, with all that, we have developed this really unique data source that we want to make available to rheumatology researchers, give them more resources for the work that they're doing. But that's all what we've established so far, and we need to keep pushing this forward. So we have a few activities that are in the works at the moment. So as you noted, we have incorporated the area deprivation index into the registry. So this does help us better understand some of those socioeconomic and social determinants of health impacts on rheumatology patients. We're pushing this forward with more research into the impact of social determinants of health on the quality of care for rheumatology patients, and looking into ways that we can then share that information with rheumatology providers and researchers as well, because we can do this work and get this data, but we can't do anything about it if we don't really understand what's happening and be able to and are able to share that with the appropriate stakeholders. On top of that, we are working to link Medicare data with registry data. That will provide a huge opportunity for us to build an even broader understanding of what's impacting the care and access for rheumatology patients, because we know one of the biggest barriers of access for patients is cost. As we noted, this is EHR data. It does not include information on cost. So with this additional information from Medicare on these patients, the care they're seeking outside of their rheumatology providers, and the cost that is associated with their care across the board. We have an opportunity to really expand that understanding and identify areas where RISE and the ACR and rheumatology stakeholders can work together to improve those aspects. And on top of everything else, the ACR as a whole has put together this wide workforce initiative to really address some of these issues that are preventing people from getting into the field and staying in the field, and being able to provide care in areas where we have so few rheumatologists. So the RISE team is part of those conversations in really determining what we can do from our side to help support some of those efforts, from helping identify where there can be some efficiency improvements in terms of how we're evaluating quality of care for the various payers and the data that's used to report to those payers, from both the federal payers to the private payers as well.
Yeah, and I'm hoping that somebody listening to this podcast maybe will also work with you someday to pair up that data with physician burnout and all of the other complexity that is impacting kind of longevity of rheumatology physicians staying in the workforce. So I'm excited to hear what you do in the future with this data set. Can you speak also to the question of the spectrum of practices participating in RISE at this stage? I know it's changed quite a bit over time, and I wondered if you could tell our listeners a little bit about that, and then also perhaps speculate on how that might continue to evolve as the registry grows.
Yeah, absolutely. So, as we've noted numerous times now, RISE, the practices that participate in RISE do tend to be heavily community-based practices. It has evolved a bit as the spectrum and field of rheumatology practices have shifted from these community-based practices to larger groups and larger health systems. So we are seeing a lot of that with RISE practices as well. So we see a lot of the community-based practices. We see kind of the shift to consolidation of practices. But one of our big drivers for participation in the registry has been meeting federal reporting requirements, specifically through MIPS. So that has skewed a bit what we're seeing with the registry. However, as noted, we are a very unique quality improvement tool and resource for rheumatology providers. So we see an opportunity to expand what feedback we are giving to rheumatology clinicians beyond just the quality measures, but also helping them understand all these other metrics that really do impact the care that they give to their patients. So being able to actually see what's happening with their patients in the area deprivation index score among their patients, and identify areas that they can essentially help their patients, even if it's not specifically tied to quality measures. And with that, we see an opportunity to expand our engagement to additional rheumatology care centers as well. So not just these community-based practices, but some of these larger health systems, and in particular the academic medical centers. Being able to see this information really is going to be key to rheumatology providers across the spectrum. And we want to be able to be there to feed back this information to those clinicians and help them understand what's happening with their patients, and take that and turn that into action with their patients that will make a difference and lead to those improved outcomes across the board.
Yeah, and I'm definitely interested to see as time goes by how RISE evolves. I remember kind of the early days of its inception and just thinking, gosh, I can't bear to hear another talk about MIPS. And it's amazing what your team has done with this registry. So I'm no longer bored by the MIPS component, and actually quite enjoy hearing the data that's coming out of the registry. So well done to your whole team.
Thank you. It certainly is a team effort.
And I want to change topic a little bit now. I like to ask my guests a little bit about their lives and careers, just to help our listeners get to know the people behind the papers. And I'm going to ask both of you a couple questions. But starting with Sharon, you've had an interesting journey. You trained outside of the US and moved to the US for residency and fellowship. I love having fellow IMGs on the show. So I wondered if you'd be able to share a little bit about at what point in your training did you decide to become a rheumatologist? And did you have any mentors who guided you on your journey?
Wow, that's taking me back a little bit. So I remember as a registrar, because I train in like a British system in the Caribbean, as a registrar in internal medicine, discussing patient cases and stories with our rheumatologist in Barbados, Cindy Flower. It was always really exciting and interesting and fun. In part, I think it was her personality. I think I've come to realize that rheumatologists in general are fun and wonderful people.
Well, I think so.
But I really always felt alert and energized after seeing a patient with her, and that ignited my interest in rheumatology. I mean, as you would know, the journey of the international medical graduate is a little more circuitous than others.
Yes.
A group of fellow IMGs recently published a statement highlighting the challenges that IMGs face in pursuing careers in rheumatology, especially research and academic pursuits. And that's due to a lack of funding opportunities. And I think sometimes job opportunities are low because of misinformation about immigration policies. I really hope that we find ways to surmount these challenges. I'm really encouraged by the attention to it right now. And I hope that we can do this to continue to enrich the rheumatology workforce with really diverse and multi-talented people. In my case, I was really fortunate to meet others along the way, like my fellowship director, Raymond Flores, and the chief of rheumatology at the VA and Howard University, Gail Carr, who definitely made my path easier and were strong advocates for me in my goals and my career.
Yeah, and I will second that comment about Gail Carr, because she was also one of my attendings when I was a fellow. And although on many days as a fellow, she scared the living daylights out of me, I reflect now on things she told me, things that, advice she gave me. And as you practice, she remains one of the voices that still comes back to me in my head of, she told me years ago that this was so, and she was right. And yeah, I think she's an amazing mentor and an amazing rheumatologist, and an incredible supporter of women in rheumatology as well. So I know we joke a little bit about the triple threat, but I wondered, you've obviously had an amazing academic career. Could you share your secrets of success? I think the struggle is real for all of us. There's always more students to teach, more patients to see, more papers to write. How do you decide what to prioritize?
Wow, how much time do we have? The struggle is real, and I am no expert. I am still striving every day to do better. I try my best to organize my time. I feel as if, like when you're dieting, you're very attentive to the foods you're eating and how much you're eating. And I feel the same thing has to do with time. If we judiciously keep track of our time and look to see where we lose it or where we spend it, we may be able to save a few extra minutes every day to dedicate to work. But this is an everyday struggle, and I continue to struggle with this as well.
Yeah, although some would say don't dedicate those spare minutes or every spare minute of the day to work, right? You want to have some outside pursuits too.
And I think what is important to you, right? Like,
right. For you, as you've grown in your career, you're now director of rheumatology at NEA Baptist Memorial Hospital in Arkansas. Are there things, as you kind of reflect back, that you wish you'd known earlier on, or wish you could tell your younger self?
I think the most crucial piece to success is having a good team around you. People that inspire you, that push you to do better, that hold you accountable, and who will also support you, be there for you when you feel as if you failed, and who can sort of like help to shore you back up. And that's both in your personal and your professional life. I found that at Howard University with our rheumatology team there. Gail Carr, Mercedes Quinones, Tara Jamshidi, all of our research coordinators, many of whom have gone on to medical school, and a host of other people have been really awesome. We spend so much time at work and at the office that we have to choose an environment carefully where we feel supported. I've also forged some meaningful connections through organizations like the ACR, AWARE, and the Caribbean Association for Rheumatology. And I think looking back, there are others who I have been inspired and encouraged by, and I wished I had kept them in my circle or maybe asked to join their circle.
It's never too late. You can always reach out.
That would be my advice, really, is to, surround yourself with good people and then reach out to people who inspire you and ask them to be a mentor or a peer colleague or accountability partner. The people in your life are probably the most important drivers to your success.
Yeah, I think that's really good advice. Spend time and energy on people who lift you up, I think is kind of the crux of it, right? So Tracy, we always hear a little bit from colleagues about their commitment to the field, and we obviously, share a common commitment to rheumatology, but we don't always get to hear what makes people come and work for the American College of Rheumatology. And you are one of the longest serving members of the RISE registry staff. And I know you have an interesting story. So I wondered, could you share with our listeners how you came to work in the field of rheumatology and what is it about the RISE registry that really energizes you?
Yeah, absolutely. So from a young age, I always knew that what I wanted to do with my career was do something that I felt made a difference. And as I was going through college, I decided that was going to be working in broadcast journalism. So I studied that for a few years and then spent some time in local TV news again for another few years and decided that really wasn't the field for me. And I didn't really get that sense of making a difference. So I left that career, pivoted a bit, and went into working in marketing and communications. And I found myself at the Rheumatology Research Foundation. And through one of my colleagues at the ACR, since we share a building, I learned a lot more about the RISE registry and the emerging field of health informatics. And it just sounded so intriguing to me. And there was an opportunity to get in to the RISE registry staff and learn so much more about this amazing tool and how it can help rheumatology clinicians and especially their patients. So I went for it, and the head of the department at the time saw something in me and decided to bring me on. And I've been working with the RISE registry now for 6 years, and I've learned that really the common threads that drive my passion across all of these activities that I've had over these years is finding answers to these questions. And working with data really is all about doing that and creating this story, figuring out what that story is and telling that story and sharing that. And that has really driven me through all of this and has really fed my passion, especially working in a field like rheumatology where you can make a difference in the lives of patients if you can find the answers to some of these questions. And as Sharon said, you find a place where you feel supported, and 10 years later, I'm still hanging out with the folks at the Rheumatology Research Foundation and the American College of Rheumatology.
That's great. And I'm hoping that you'll continue to bring your broadcast news skills to the field and kind of advocate for us at so many levels. It's really great to have you on the team.
Thank you so much. And I hope I can do that.
And I want to thank you both, Sharon and Tracy, for joining us on the show to discuss this incredibly important and thought-provoking manuscript.
Thank you. It's been a pleasure being here.
Thank you for hosting us.
And in this episode, we also want to thank the rheumatologists and rheumatology patients who contribute data to the RISE registry. Over many years, this registry has grown exponentially, both in size and in impact. And with that growth, the value of the registry now extends beyond its initial purpose of helping individuals provide data to increasingly answering overarching questions about rheumatologic care. We thank you all for listening to this podcast. ACR Journals on Air is a production of the American College of Rheumatology. Please follow at ACRoom on social media and rate and subscribe to our podcast at acrjournalsonair.org or wherever you get your podcasts.